My name is Courtney Belomo, and I'm a hematologist with the New York Oncology and Hematology. The purpose of this video is to review the indications and toxicity for a new revolutionary technology called chimeric antigen receptor T cells. To start the lecture, I wanted to give you a reminder of the overall immune system. Pathogens need to be exposed on dendritic cells, which can then activate macrophages and monocytes. There is secretions of multiple cytokines, including interleukins. You need both CD4 and CD8 T cells to come together to actually make an immune response. This is a complex and multi-step system to actually get your immune system to activate T cells. Chimeric antigen receptor T cells look to activate autologous T cells in a different way to make an immune response against the cancer. What happens for the patient is they undergo apheresis, removing their white blood cells. This white blood cell product is then transported to a pharmaceutical company where the T cells are isolated. There's a new construct placed into the T cells, which results in a chimeric antigen receptor T cell. This has an extracellular domain, which has a specific target to the cancer, and an intracellular domain, which has co-stimulatory signals to activate T cells. The concept is that one chimeric antigen receptor T cell needs to find one cancer cell to make it a durable immune response. This is already approved in non-Hodgkin's lymphoma and acute lymphoblastic leukemia, where the target is CD19. However, it is also coming down the pike for acute myeloid leukemia, multiple myeloma, mantle cell lymphoma, follicular lymphoma, and is being evaluated in solid tumor cells as well. Again, to review here, patients will undergo pheresis in our outpatient office at our Albany Medical Center site. All of the white cells will then be transported to the pharmaceutical company where T cells will be isolated. We are specifically using a Juno product, which will isolate out CD4 and CD8 cells. However, other products on the market don't necessarily do this. These cells will then be stimulated with various interleukins and injected with a lentivirus carrying the new construct. The T cells will proliferate, be placed in a bag, and returned back to the patient. All of this happens in the outpatient office, and more than likely, none of you will be involved just yet. I wanted to start by explaining where this technology has already been approved. It is approved in third-line diffuse large B-cell lymphoma. There are two different products on the market, Yescarta and Kymriah. What I think you can really notice by this is that in the first photos, the yellow from before goes away for after. So even if you don't know how to read a PET scan, you can see that there's been a significant response. Typically, right now without CAR-T, I would say on average, third-line diffuse large B-cell lymphoma patients, most of whom have failed autologous stem cell transplantation, have a 15% response rate to conventional chemotherapy and a less than 10% cure rate. CAR-T is changing that to approximately 50 to 60% overall response rate. It's important to note that not everyone is cured of this, but we are seeing much better results than we have in the past. If you look at these center graphs, you can see that for the first 6 months, you do lose people, and that is relatively emblematic with the treatment not working. But if you hit the 6-month mark and you haven't relapsed, you can see a durable complete response. You can also see some partial responses who change into potential complete responses. Most of the time, relapse within 6 months is indicative of it not working. We don't have data long enough to know whether or not, if they relapse at 2 years or 3 years, if we could re-challenge with CARs. The other place where CAR T has been approved is in pediatric and young adult acute lymphoblastic leukemia up to the age of 25. There are a couple things that I want to point out from this slide. The first is that these patients tended to be on 6th, 7th line of therapy and are now still alive 5 years later. It has as high as a 70 to 80% response rate. It's hard to know if the response rate is better than lymphoma because some of these patients did get a second allogeneic stem cell transplantation. And you can see in the beginning months that you lose less people than you did for diffuse large B-cell lymphoma. Also, if you look all the way over at the right at the forest plot, anything that crosses a dotted line is not statistically significant. What you can see is that no matter what your disease burden was, whether you had stem cell transplant, how many prior lines of therapy, it was statistically significant in everyone. This was the start of this movement for CAR T and why it became important. What I actually find the most fascinating is the middle graph here. So you can see the lightest blue is a cohort of patients that didn't respond, and the deeper blue, which is the most common, are people who are in complete remission and what we call MRD negative. So MRD stands for minimal residual disease. And in my neck of the woods, this means that patients are at higher risk of relapse post-transplantation. They tend to not do as well overall. And anyone that goes into transplant with minimal residual disease has a higher likelihood of relapse. What I find fascinating about this graph, which is actually the 5-year survival data at this point, is there is a cohort of people with minimal residual disease who do not actually have clinically significant disease, suggesting that even 5 years later, these T cells are still working to keep people's cancer at bay. The science behind that is very fascinating about what that will mean for the future of cancer. However, CAR T comes at a cost, and I think that we need to spend some time talking about toxicities. We tend to separate toxicities into the first 8 weeks versus more than 8 weeks. So in the more than 8 weeks category, what we don't know is what it looks like 15 to 20 years down the road if you've had one of these products. All patients who undergo CAR T therapy are automatically enrolled in a long-term follow-up for up to 15 years. We don't know if by injecting a lentivirus into a T cell, you're going to end up with a whole bunch of people with T cell lymphoma or other types of autoimmune disorders down the road. For diffuse large B-cell and acute lymphoblastic leukemia, the target is CD19, which can lead to significant B-cell aplasia, putting people at infectious risk. It can also lead to aplastic anemia as your bone marrow doesn't recover as well. However, within 8 weeks, everything tends to be self-limited, but it can be quite a roller coaster. Patients can get cytokine release syndrome, which I'm going to go over in more detail in a second, neurotoxicity, macrophage activating syndrome, like you would see in hemophagocytic lymphohistiocytosis, cardiotoxicity, which can be as simple as QT prolongation to cardiovascular collapse and stress-induced cardiomyopathy. They can get anaphylaxis due to the preservative that the T cells are stored in. They will also have gotten chemotherapy to get them ready for these new T cells, So they can have febrile neutropenia, infection, and DIC in the setting of that. Finally, some patients come in with bulky disease, masses as large as 20 centimeters, and they can get tumor lysis syndrome from that. The first toxicity I'm going to talk about is cytokine release syndrome. The timing of this depends upon the product that the patient is receiving. For Yescarta and Kymriah, it tends to occur at 3 to 5 days, but Juno can actually peak at 5 to 7 days. Low-grade toxicity involves something as simple as a high fever to mild hypotension that responds to fluids, where high-grade toxicity can really involve multi-organ failure. Patients can need to be intubated due to hypoxia, on dialysis due to renal failure, require ionotropes due to cardiovascular collapse. They can get neurotoxicity, which I'm going to talk about in a second. They can get arthralgias, fatigue. It feels like a flu on steroids. And what it really is a capillary leak syndrome of sorts. You get severe spikes in interleukins, which result in cytokine storm. We actually attack interleukin 6 as part of treatment, but more than likely there are other interleukins involved. So daily we are actually looking at inflammatory markers such as C-reactive protein, ferritin, and LDH, because patients can behave like an HLH patient. We're looking for DIC with fibrinogen, PT, PTT. Depending on the grade of toxicity, these patients will either be on the oncology floor on D4 East or in the MICU on D3 East. The CAR-T team will be involved in all patients. If you have cytokine release, you are more apt to have neurotoxicity, so there will be neuroexams every 8 hours at least, with pulse oximetry every 4 hours, and you are still ruling out that this is not infectious in the setting of febrile neutropenia. This occurs right now with our current products in more than 75% of patients. However, the Juno product is seeing about 40 to 50% of patients, and the goal of their trial is to really do this entirely as an outpatient. That is really where the field is moving, which is exciting, but our first priority is going to be patient safety. You will on average see at most 2 to 3 patients admitted a month with this. In regards to treatment, it is entirely based on grading. Every patient that's admitted will have the grading system there, but management will come down to what the CAR-T team delegates. We want to be an institution that is accredited for cellular therapy, which means that we will have a tight control over these patients. However, you can see that initially it's supportive care, and eventually we're looking at things like tocilizumab, which inhibits the interleukin 6 receptor and thus shuts down the cytokine storm. We are doing that with or without steroids, and we'll talk about how that can interact with neurotoxicity in a second. Typically, tocilizumab is only given on the first day, but it may also be given on the second day depending on the grade. You can also see that you can track based on the pre-infusion C-reactive protein, the likelihood of getting severe cytokine storm, and the C-reactive protein is a direct marker to disease burden in these patients. Neurotoxicity, as a clinician, is one of the most fascinating things I've ever seen. Patients typically get this within 7 days, but can occur up to 28 days or even 60 days. They're actually not allowed to drive for 60 days given the risk. Neurotoxicity in this population is more cerebellar and cognitive than anything else. While patients can get motor paresis or sensory deficits, it's far less common and a sign of actually worsening disease. Most of the time they get dysmetria, confusion. For example, younger patients can lose the ability to text. Older patients can not know the names of their grandkids, and they can go from doing Sudoku in the morning to missing a word or writing funny at noon to urinating on the floor in the afternoon to herniating at night. So picking up these subtle differences is really important. Anyone that has elevated fever and any signs of interleukin elevation within 36 hours after receiving the product is a high risk for cerebral herniation. The way we're going to manage this is to pick it up early. That's the safest way to manage this. So first, we're going to avoid neurotoxic agents. So not just, so everything that can make a patient confused. They won't get Benadryl with transfusions. They won't get sleep agents. We're going to be avoiding all of those things. House staff, whether in the MICU or on the oncology floor, are going to go do serial 7s, finger to nose, object naming, orientation, following commands every single day. The nurse is going to do a handwriting assessment and orientation assessment every 8 hours at least. We have a neurology CAR team headed by Sue Weaver that's going to be seeing these patients on the day of admission. Our neurology residents will get involved if it happens on the weekend. And if anyone gets symptoms, they're going down to the ICU. They may need an MRI, CT scan of the head, EEG, lumbar puncture. These patients can have seizures, so they may be put on seizure prophylaxis. They may get ophthalmic examinations to look for cerebral edema. Managing them is, again, based on their grade. The ICE score actually looks at orientation, the ability to name objects, how do you follow commands, writing, can you do serial 10s, and gives you a score. And then with their level of consciousness and neurologic findings, you can come up with a grade, and then that will allow us to determine what to do. All patients will be placed on Keppra if there's any signs of neurotoxicity. At this point, we may downgrade that as we learn more about what neurotoxicity looks like. We think that potentially the cause of neurotoxicity is actually a raise in interleukin levels. So as we give tocilizumab to block the interleukin-6 receptor, it raises interleukin-6 levels, which cross the blood-brain barrier and then cause neurotoxicity. So you may see us using the steroids and tocilizumab together more in the hopes of preventing neurotoxicity. This is a hypothesis. It hasn't been studied yet, but the neurotoxicity is fascinating about what this means for this disease. We do give dexamethasone and solumedrol based upon the grade. Cardiotoxicity is also very fascinating in this disease. There is a single paper on cardiotoxicity. People have been talking about neurotoxicity and cytokine release syndrome since the inception of CAR-T, but cardiotoxicity is relatively new in the conversation. So we don't honestly really know what to do. I think the key points is that it can manifest in a myriad of ways. They can get a stress cardiomyopathy, which is by far the most concerning. It can be simple hypotension, a little bit of congestive heart failure, QT prolongation from not only the antibiotics that we're using, but the anti-nausea meds, and all those other things can promote that. They can get a lot of ectopy from the cytokine storm, which can lead to VTAC, AFib. We've even had some patients with sudden cardiac death. You can get worsening myocardial strain, and that'll actually become a really important evaluation up front A lot of these patients have had cardiotoxic agents as part of their chemotherapy, so everyone will undergo an echocardiogram with strain evaluation. If they have evidence of strain, we may have them see a cardiologist beforehand to make sure it's safe to give this, because when they get stress cardiomyopathy, you can actually see the strain raise over even 24 hours, and then they end up in significant heart failure. We're going to look at their CPKs, their C-reactive protein, their BNP to make sure that there's no signs of red flags ahead of time. If they're not responding to fluids, they may be transferred down to the MICU. Everyone is staying in the MICU. We feel that that's the safest place for them, but we will get cardiology on board. The key to remember is that this is a capillary leak syndrome. So while they may look edematous, they're actually intravascular depleted in the beginning. So it's important to use Levophed to continue to give them fluids despite that. Once they end up in cardiogenic shock and real cardiovascular collapse, it's at that point that you start to see LV dysfunction. So you need to do serial echocardiograms on these patients. It's at this point you may want to use your inotropes, your diuretics. You're definitely using tocilizumab and potentially even steroids. So I think what's important is to note what's our responsibility versus yours. Our first priority is to make sure that these patients are safe. So that means that a member of the CAR T team will be available to you 24/7. So the director of cellular therapy for NYOH is Dr. Rosinski. I'm going to be the hematology lead. We have a physician assistant, Brianna Fuller, who will be our advanced practice provider lead. Right now, because everything is housed within research, we have a research nurse, Sue Brignell, and our head of research, Amy Zokolowski, who have been integral in this project. I will tell you that commercial product is coming, we think, by summer to fall of 2020, and we will more than likely be adding some members to our CAR T team when that happens. Desma Caputo is now our practice manager for our Albany Medical Center site, and she's our administrative lead. What we're going to be trying to make sure that we're doing is, first and foremost, you may not see these patients for months at a time, depending on how we enroll and whether or not they actually need to be admitted. So we are going to be making sure that we do weekly education with the residents and with the attending. All patients will either be on the red team or in the MICU and nowhere else. A member of our team is going to be seeing the patient daily and leaving a note. We will also be touching base with the nurse as well as the resident's bedside every day. We're going to be doing daily neuro exams because we think 2 heads are better than 1. The expectation is still that the internal medicine residents will also be doing it. We're going to be doing mini mental status exams twice a week, or potentially more often if the protocol demands that. We are going to be in charge of coordinating all of their care. So there's going to be a sticker up on the wall saying this is a CAR T patient. There's going to be a sticker on the front of the chart saying that this is a CAR T patient with our direct phone number. So while you'll have the grading system, you will have nothing on management because we want tight control over these patients. We think that's what keeps them safe. And we may loosen that as time goes on, but not in the beginning. Myself or Dr. Rosinski will be on call and with the ability to come back in the middle of the night 24/7. You may during the day get Sue as our primary contact, but everything will go through one of us. We're going to determine when you use steroids, when you order tests, when they go to the MICU, when do you add seizure prophylaxis. All of that is going to be based on us, and we're hoping that we'll be educating you along the way. We talked about inpatient procedures already, and on the front of the chart there's going to be these reminders, but it's going to tell you when you need to call us. We want to know if there's a slight fever. We want to know if the blood pressure drops. I want to know what the pulse ox is and whether there's any neurologic changes. We want to know if all of a sudden they look like they're septic because their urine output decreased. I don't want to be the one in charge of their diet or ordering their labs. We will be taking care of the things that are related to CAR T. And now the inpatient/outpatient team responsibilities. So first, I want to make sure everybody knows we are hoping to bypass the ER. All of these patients will either be on the oncology floor or in the MICU. We have trained the ER, but we're not planning that they'll be a routine part of therapy. We, of course, have a backup if that happens. What Albany Med is kind of committed to is that potentially giving all of these patients a bed within the hour, which is how we model our autologous stem cell transplantation. So on D3 and D4 East, our nursing responsibility is that they're going to be coordinating with the CAR T team. They're going to make sure that they've done the education they need to take care of these patients so that they know what to subtly look for. They're going to be doing neuro exams with handwriting tests and finger to nose. They're going to be the ones coordinating with the stat nurses who have also already been made aware. Outpatient apheresis is going to be looking for cytokine release and neurotoxicity as well, and calling the number to see if these patients need to be admitted. They're going to be in charge of their transfusions. All of our patients are going to have a band that goes around the wrist that says what to look for, as well as the number to the CAR T program. We have a bat phone, so you're going to call a single number, and that's going to be directed to who's ever covering at that moment. So you guys don't have to go through the service and wait for a phone call back. You should be getting someone directly on the line. Our Albany Med pharmacy is going to make sure that we have 2 doses of tocilizumab per patient, which is required by the FDA, and then also within an hour of the order being either given verbally or handwritten, where tocilizumab is actually able to be given, because time is really of the essence of these patients, especially if they're coming from the outpatient setting to inpatient. Our internal medicine residents are going to be on both the red team and in the MICU. So they're going to be doing neurologic exams, naming of 3 objects, serial 7s, orientation. They're going to be admitting patients to the red team overnight or to the MICU. And then again, they're going to be handling any acute issues and communicating with the CAR T team. We want to be involved. The culture here is very much don't call an attending at night, and we really want it to be the opposite. We'd prefer for you to call us and for us to say that it's nothing and that these patients be safe. Our neurology lead is going to be Dr. Weaver and her nurse practitioner, Maeve Dargish. They are going to do a full neurologic assessment on the day someone gets infused, and then round when appropriate in the hospital. On the weekend, if someone crashes, our AMC neurology team will get involved at that point. They're going to help us interpret the LP and the EEG and the MRI. Pulmonary, so they're going to be assigning patients, obviously, to teams and know that all the patients go to the house staff team. They're going to be accepting these patients to the MICU and figuring out the bed situation there and who can transfer to other units. And again, they're communicating with the CAR T team daily and for any acute issues. Our cardiology leads, we have one for both university cardiology and capital cardiology. You're going to consult them based on the day, just like we do now. They're going to round daily in the MICU if there's any signs of cardiotoxicity, and they're going to really be spearheading our cardiac supportive medications, as well as our routine echo interpretation and when strain has worsened. Our infectious disease team is Dr. Romani and Dr. Kennedy, and they're going to help guide febrile neutropenia, what antibiotics to use, especially in the setting of the B-cell aplasia and the significant pancytopenias you might see. We are also making a designated CAR T card that talks about cytokine release, neurotoxicity, cardiotoxicity that patients can carry, that providers can carry around in their pocket. We will still be doing the management in the beginning. So a lot of these cards won't have management, but you will be able to reach us no matter what. Even if we are not in the state, you will still be able to reach us. I also think that CAR T and T-cell manipulation is the future of cancer. So we're looking at CD19 targets in a myriad of different lymphomas. BCMA, we think, is going to be approved, which is B-cell mature antigen. It's going to be approved in September 2020 for multiple myeloma. Hodgkin's disease, CD30. These are CAR Ts, but I will tell you we're also looking at autologous T cells and routes of administration, all of which are going to change how we think about oncology in today's day and age. This is going to be like what penicillin was to antibiotics. It's changing the paradigm of what we talk to our patients about. It is also coming down the pike for solid tumor, but solid tumor is a lot more difficult. For example, if you have an EGFR positive lung cancer and I give you a CAR T directed against EGFR, you will probably desquamate all of your skin. So how do we combat that? So right now we're using things that are specific: HER2, interleukin 13R alpha 2, prostate specific mature antigen that can attack cancers that we know don't have a lot of crosstalk. They're all in clinical trials at this point. We are also looking at lung cancer, ovarian, liver, things that are helping change how we formulate cellular therapy, and things that we don't know the answer to yet, which is why it makes this field so exciting. So first of all, should we be combining this with checkpoint inhibitors? Should we be looking at how the T cell receptors interact with one another and figure out a way to make that work together? What if someone's cytokine release gets out of control, or they're about to herniate? Are there suicide genes that we can inject and shut down the T cell activation? Should we be giving people a second infusion of CAR T if they relapse 2 years later? We don't even have that data yet. We're looking at autologous T cell products. So for example, we're going to be doing a trial looking at screening specific types of lung cancer, seeing if they have a specific mutation, collecting their white blood cells, and then being able to use this product down the road if initial therapy fails. There's also an AML product that looking at the T cell gene receptor, has very little cytokine release because you don't need the co-stimulatory signals, which is really what leads to T cell activation and proliferation, because the T cell receptor will do that on its own, and you can expand epitopes without actually needing to know what's wrong with the cancer. It's a really exciting time to be an oncologist. However, these drugs are $500,000. So when do you use them? So for example, for multiple myeloma that we put everybody on maintenance, they live 10 years. When do you insert CAR T? Do you insert it in the beginning so you don't give these patients maintenance? Are we as a field going to be okay with that? Do you give it third line, fifth line? What's the cutoff in age? All those things are difficult questions, and they change how we talk to patients, changes how we think about palliative care and goals of care. So we have people calling the office irate that they're 90 and won't get CAR T. So where do we draw the line, and what makes sense for overall healthcare cost? There are also off-the-shelf T cell products. So instead of using autologous products, we're going to say, oh, you have a part HLA match and you have an EGFR or HER2 breast cancer. We're going to take this off the shelf, give you your CAR T within a week rather than the 3 to 4 weeks it takes to manufacture it. There's also certain institutions looking at, should we be using CD4 versus CD8, like Juno's doing, versus doing them a lot earlier when they haven't been exposed to so many antigens? And does that change cytokine release? Does that change efficacy? These are all questions we don't know the answer to. There are trials ongoing for both metastatic breast cancer to the brain as well as lymphoma with CNS relapse that show that if you inject CAR T weekly in lower doses into the brain, it creates not only a response in the brain without toxicity, but also treats systemic disease. So is everyone going to be walking around with an Omiaport at some point? All of these questions we don't have answers to, but I'm hoping that this lecture showed how exciting this is, how excited we are to bring this to the NYOH Albany Medical Center site, and how that will interact with Albany Medical Center as a whole. We are available for questions if anybody has any at any time, but we're hoping that you're going to be as excited as as we are. Thank you for your attention.